First, I'd like to thank Dr. Schulman and Dr. Yuza for letting me speak. I have a tall order of doing 6 minutes of all the primary bariatric procedures that we have, so I'll try my best. These are my disclosures. None of them are particularly that relevant to this. So in terms of the current options that we have outside of endoscopic management, we know that in terms of lifestyle modifications, it can be quite variable in terms of results, and it's less than 5% most of the time. Obviously, with now GLP agonists, receptor agonists, that have changed things a little bit, so I'm not going to touch on that on this talk, but, and we also know bariatric surgery is quite effective and durable. It's more permanent, obviously, but complications can be up to 30%, and not all patients are eligible to this given the guidelines. So the talk for today is really focusing on where does endoscopic management fit into this. I think it's a good in-between option in terms of between lifestyle modifications, pharmacotherapy, and surgical management. So this is really a good bridge, sometimes a bridge management, or it can be your primary management of weight loss. So in terms of the different procedures, they can kind of be categorized in different ways. We're going to go through these really quickly, given that I only have less than 6 minutes for this. So we're going to go through a lot of these. So in terms of intragastric balloons, this is a space-occupying device that goes into the stomach. They can be either filled with saline or gas. They're left in typically for up to 6 months, and then they do have to be removed. They were first introduced in the 1980s, and for the most part, it's between the BMI between 30 and 40. A lot of the complications are, as you can imagine, because it's a space-occupying device, abdominal pain, nausea, vomiting. In terms of less common ones are more like whether the balloon actually goes. I think there was like one case study of the balloon going distally, but for the most part, a lot of nausea, pain, and minimal side effects. These are the different types of balloons that are out there. The first one is probably the most common, which is the Orbera. The Obalon and Ellipse are different in the sense that they are ingested, and then the balloons are then subsequently inflated. But these are just the different type of balloons that are out there, and they all sort of occupy space they can be occupied up to a liter, and that kind of causes early satiety. So in terms of their efficacy, you can see here that it has had some, in terms of estimated weight loss, or excess weight loss, up to like almost 25%. And it can also improve metabolic outcomes as well. It doesn't have to be just a one-time therapy. You can repeat it after every 6 months. But there has been, obviously, because once the balloon's removed, you can have, may not be as durable over time. This has been approved, but I don't think a lot of people use it. It's a transpyloric shuttle. It's similar in terms of, it's almost like a ball valve technique in which there's a cylindrical shuttle, and it sort of essentially obstructs the pylorus, and it causes delayed gastric emptying. But again, I don't think a lot of people use this altogether. Aspiration therapy is another method. Essentially, it's like a glorified PEG. So essentially, you put a PEG that's about 30 French and aspirate gastric contents. You can aspirate up to 30% of your meals. As you can imagine, you do have to make sure the patients do chew their food quite thoroughly and drink a lot of water when you do this, because it can get stuck. But it was approved and in the same kind of BMI range that we've been talking about. But again, it may not be the most glamorous way to cause for weight loss. In terms of efficacy, as you can imagine, if you're aspirating 30% of your meals, it can be quite effective compared to other bariatric endoscopic interventions. And there's not the same, in terms of adverse events, it's very similar to a lot of the complications that we see with PEG tubes. I think this is probably the one that a lot of us want to talk about, is endoscopic sleeve gastroplasty, essentially doing a sleeve gastrectomy, but all endoscopically. In terms of the goal, it's very similar. You're essentially creating a tubular-like stomach and reducing the gastric capacity, and that causes increased satiety and induces ghrelin reduction. And of course, now with the MERIT trial coming out and new HCPCS codes, this is going to be a lot more popular with your patients, and you're probably going to hear a lot more about this going forward. In terms of the adverse event rates, it's quite low in comparison to laparoscopic sleeve gastrectomy. Probably the most common ones are pain, nausea, and vomiting. Other ones are sort of perigastric fluid collections or abscesses that sometimes require drainage, but it's generally well tolerated. Was lucky to have a video from Dr. Galvanito, but essentially we're using the same endoscopic overstitch device that we've already seen today, and essentially going along the greater curvature to create that kind of tubular stomach. There's different suturing patterns that I'll show in the next slide, but everyone's a little bit different in terms of how they like to fashion their sleeves, but essentially using the same overstitch device that we've seen to perform this gastric sleeve. So these are just the different types of patterns, and they've all been relatively comparable in terms of creating it, so there's not one chosen over the other, but these are just the different type of suture patterns. And in terms of their efficacy, you can see it in terms of total weight loss, it can be up to 20%. The Merit trial did show that it was up to 49.2% in terms of sustained weight loss. And not only weight loss, but also the metabolic comorbidities. There's been shown that it has helped in terms of type 2 diabetes management, insulin responsiveness, as well as cholesterol and hypertension statuses. So it's not just the weight loss, it's also the metabolic comorbidities that this is particularly effective. So in terms of how it compares, it's pretty comparable to laparoscopic sleeve gastrectomy, and even a study has suggested that it can be more cost-effective even compared to GLP receptor agonists, and it can actually have more sustained, greater weight loss over a 5-year horizon. So in terms of short-term effects, definitely the medications do help, but this can be a little bit more durable in comparison to medications. So in terms of pose, this is a different type of endoscopic suturing system. It's a 4-channel device. Essentially, there's different ways. Originally, it was developed where you suture and do different full-thickness plications in the fundus and the proximal gastric body, but now full pose 2.0 is more from the intradura to the proximal gastric body, similarly creating a tubular-like stomach. It has a similar safety profile and improves metabolic comorbidities as well. This is a little bit, I don't think people do this as much as really just injecting Botox to delay gastric emptying, but it hasn't been really approved, and I don't think a lot of people do that, but it is an option that you can do as well. But again, mostly used for gastroparesis, but similar kind of principles. In terms of malabsorptive techniques, this is similar to inducing like an endoscopic gastric bypass. You're essentially placing a sleeve in to prevent absorption of nutrients and then causing weight loss that way. There are a couple of different ones that are on the market, but they're not FDA approved quite yet. The duodenal jejunal bypass sleeve is where the sleeve is endoscopically placed near the pylorus and then into the proximal jejunum for about 60 centimeters. They're put in for about a year's time. And they also have good sustained weight loss as well. But again, the FDA clinical trial's on hold just because there was a higher risk of infection with hepatic abscesses. So right now it's still not out for us quite yet. Similarly, there's an endoluminal bypass where the sleeve is anchored to the GE junction and going into the jejunum, but also in for a year's time, but still in trial right now. This is not necessarily weight loss, but it's more for diabetes. It's still being discovered whether it does help with weight loss, but essentially ablating the duodenal mucosa distal to the ampulla vator to see, and that just because in terms of diabetic patients, we know that their duodenal mucosa is hypertrophied. So this is the thought is that this will help with type 2 diabetes management and subsequently also weight loss because of the ablated and malabsorption. This is the last one, I promise. This is the self-assembling magnets. Essentially, you're placing magnets endoscopically to create an anastomosis between the stomach and the distal jejunum or proximal ileum. The magnets compress and create an anastomosis, and then the magnets are then passed in the GI tract afterwards, and that obviously causes weight loss as well. There's not significant adverse events, and it's still in trials right now. So essentially, a lot of the current things that we use, I think a lot of focus is going to be going towards and ESG at the moment. The other ones are still really in the process, but the one that we really are looking at is ESG. And we can really think about using it sort of for those patients that don't necessarily qualify for surgical therapy and be able to be a bit of a more durable solution. Thank you very much.